Hey guys, this is John Franco for you. I hope that these videos are a great use of your valuable Step 1 study time. We're going to do some anatomy and physiology. So let's go ahead and get started. Let's start with this anatomy. This is high yield. This is a very high yield image because many patients suffer myocardial infarctions. Test question writers can easily integrate findings on an electrocardiogram and then expect you to tell them which coronary artery is involved. They do this to see if you know how to localize the infarct to a specific coronary artery because people do this all the time in real life. Now, the coronary arteries originate here at the root of the aorta, just above the aortic valve cusps. Now, imagine that the leaflets are right here. The aortic valve leaflets actually block the opening to the coronary arteries in systole, which is why the majority of the blood enters the coronary arteries in early diastole. Now, the right coronary artery gives rise to the right-sided part of the circulation, and the left side branches off into the left main coronary artery. So we have the right coronary artery and the left main coronary artery. Now the left main coronary artery passes between the pulmonary trunk here and the left atrial appendage, you can see right here. It then divides into the left circumflex and the left anterior descending. Now the LAD descends anteriorly within the anterior interventricular groove towards the apex. This is the apex. Imagine here there's a groove. It's not shown in your diagram, but this is where it is. On its course, it gives off branches to supply the anterior two-thirds of the interventricular septum, the anterolateral papillary muscle, and the anterior surface of the left ventricle. Now, a good quick way to remember this is to understand what is directly under the LAD, which is the interventricular septum. This should make a lot of sense to you because the interventricular groove of the pericardium is sitting directly above the interventricular septum of the myocardium. Now this is one that is particularly high yield because an infarcted interventricular septum will actually increase your risk for rupture and the creation of a ventricular septal defect. This is because the infarcted muscle leaves non-viable myocardium that will be prone to rupture when macrophages are removing all of the necrotic cells from that area. Alright, now what about the circumflex? Why is it called the circumflex? Well, it literally winds around and circumflexes towards the posterior wall of the left ventricle. There is a large branch of the left circumflex, which is called the left obtuse marginal artery, that aids the left anterior descending in supplying the left ventricle. Now notice how the left circumflex also supplies the anterolateral papillary muscle. This is why it is not the most commonly ruptured papillary muscle after infarction. It has dual blood supply. Now what about the right coronary artery? It delivers blood to the right ventricle via some acute marginal branches. In 85% of the population, the right coronary artery will give rise to the posterior descending artery. In 8% of the people, the PDA arises from the left circumflex, so watch out for this. And in the remaining 7%, it comes together as a contribution from both the LCX, or left circumflex, and the right coronary artery. Now don't worry about these percentages. Just remember that in a large part of the population, 85%, the PDA comes from the right coronary artery. But if it's not there, then you better check out the left circumflex because it could have an origin there or it could be a dual contribution from both. Now, if the left anterior descending supplied the anterior two-thirds of the interventricular septum, which artery do you think supplies the remaining posterior one-third of the interventricular septum? The posterior descending. It is sometimes named the posterior interventricular artery because it supplies the posterior one-third of the interventricular septum and it also supplies the posterior walls of the ventricles. Now the posterior descending artery courses on the posterior side of the heart towards the apex. Notice coursing here. Notice how it's directly on the opposite side of the LAD, which is on the anterior side, and they meet at the apex. Now let's discuss some other important high-yield cardiac anatomy related to the right coronary artery. This might be a question on your exam or how you save a patient's life. Now the AV nodal and the SA nodal arteries supply the AV and SA nodes. Occlusions of the right coronary artery can lead to fatal arrhythmias because if the cells in the SA and the AV node are not being adequately perfused due to infarction of the right coronary artery, who is going to be depolarizing the heart in normal fashion? No one. These cells are going to die. There will be abnormal depolarizations produced by cells not located within the SA or AV node, or in the specialized conduction system. We call these ectopic beats. Now, another incredibly high yield thing to remember is that the blood supply to the posteromedial papillary muscle is only from the posterior descending artery. This makes it one of the most prone for infarction because it does not have a backup blood supply. It only has one from the PDA. Watch out for this in a vignette that describes someone with a suspected myocardial infarction with a new onset murmur of mitral regurgitation. Now, the last high yield fact, which I definitely remember was on my step 1 exam, is the relationship of the posterior part of the heart with an important nerve. Your question might go something like this. You have a 54-year-old female with a history of rheumatic heart disease that has been followed by her cardiologist for mitral stenosis. She had a recent transesophageal echocardiogram, or TEE, to check out a recent onset of hoarseness and dysphagia. These have been continuing to get worse over the last couple of months. Now, what results would the TEE most likely show? Well, this is what we're looking at here. The whole point of this question is to make sure you understand the relationship of the left ventricle to the esophagus and the branch of the vagus that we're interested in, which is the left recurrent laryngeal. Remember, it comes in here and loops around and then goes back up. It recurs back towards the superior part of the body. The left recurrent nerve loops under the ligamentum arteriosum on its way back up towards the head. Now, in a woman that has had a chronically elevated pressure in the left atrium due to mitral valve stenosis, eventually what's going to happen is that the left atrium is going to balloon out and it can potentially compress surrounding structures. So if the left atrium is huge, it can compress the esophagus, leading to dysphagia, or it can compress the left recurrent laryngeal nerve that we're interested in and cause hoarseness. So why does it cause hoarseness? Well, what does the left recurrent laryngeal nerve innervate? It innervates the intrinsic muscles of the larynx that control voice. So physiology is the bulk of the cardiovascular section. Don't let the equations, the numbers, and diagrams zone you out. You will get tested heavily on these concepts because question writers love fundamentals, especially physics. So let's get it. Now these equations are simple, but the concepts are more important behind these equations. So we're going to discuss the equations as we write them out. This stuff is kind of boring, but repetition is key. The more you see these equations, the greater chance that you have to remember them. Now first what I want to talk about is that cardiac output equals heart rate times the stroke volume. This just tells us that the heart can pump out a given volume of blood, which is stroke volume, in a given amount of time, which is heart rate. Fick principle is another way to calculate cardiac output, which tells us that cardiac output equals the rate of oxygen being used divided by the arterial oxygen concentration minus the venous oxygen concentration. So this principle is based on the fact that oxygen is extracted from tissues at a rate proportional to blood flow. So we can measure and compare the arterial oxygen and the venous oxygen content to see how much the tissues have pulled out the oxygen from the blood. So think about it like this. If a patient has systolic dysfunction, the cardiac output is going to decrease, right? Because they have difficulty contracting and pushing blood out. So here's our capillary, and the flow will be very, very slow through here. The tissues will have a greater opportunity to pull out oxygen from the arterial blood that is being delivered to them because it's just not flowing out and back to the heart as fast as it normally would because this person has systolic dysfunction. Now you have to do blood gases to obtain the arterial and the venous oxygen content values. And you also need to analyze expired air to get the total oxygen consumption, which helps us calculate the rate of oxygen use. So this method of calculating cardiac output is rather impractical to say the least, but your exam isn't about practicality. It's about fundamental concepts, so do not get discouraged if you don't feel like you actually will ever use this. All right, the next equation for us to discuss is mean arterial pressure. So mean arterial pressure equals cardiac output times the total peripheral resistance. So this is the product of cardiac output and total peripheral resistance, right? If this equation looks familiar, it's because it's really just a basic equation of fluid flow, where pressure equals flow times resistance. In this situation, flow is our cardiac output, and total peripheral resistance is just resistance. The resistance is provided by the small arterioles that precede large capillary networks. So mean arterial pressure can also be calculated by the addition of 2/3 of the diastolic pressure plus 1/3 of the systolic blood pressure. Well, that doesn't sound like a true mean, does it, right? Why are we in these weird 1/3 of stuff? Well, mean arterial pressure represents the pressure in a single cardiac cycle. Our heart spends a lot of time filling itself, a lot more time filling itself than emptying it. So this is represented in this equation. A lot more of the equation is represented by the diastolic blood pressure. So let's keep rolling before we zone out. One more is the pulse pressure. This is defined as the difference between the systolic blood pressure minus the diastolic blood pressure. Yeah, okay, so who cares, right? Well, it's important because an increased or decreased value is associated with certain pathologies. So let's write these out. Think about it like this. Pulse pressure is proportional to the stroke volume and inversely proportional to the arterial compliance. So how much blood you put into the arteries is going to determine the initial systolic pressure. So in conditions that limit the stroke volume or the ejection of blood from the heart, you would expect a subsequent decrease in the systolic blood pressure and therefore also a decrease in the pulse pressure. So what conditions are we talking about? Well, we're talking about aortic stenosis because a stenotic valve decreases the amount of ejected blood. Another situation is cardiogenic shock or heart failure. Both have severely decreased cardiac output because they have a decreased stroke volume, and this is reflected in the decreased pulse pressure. A decrease in stroke volume because of a decrease in cardiac output leads to a decrease in pulse pressure. Remember, pulse pressure is systolic minus the diastolic. Now the same thing goes for the opposite situation, where we have an increase in pulse pressure. Now this occurs in situations in which the stroke volume is increased. So for example, hyperthyroidism, where we have increased amount of thyroid hormone activity, causes an increase in transcription of beta receptors in the heart. So there's an increase in the contractility or the contraction force and the heart rate. This leads to an increase in the pulse pressure because the initial systolic blood pressure reading will be higher. Now, in obstructive sleep apnea, we also turn up the sympathetic nervous system because this is an important way that the body responds to obstructed airway, decreasing the oxygen saturation of blood. The chemoreceptors in the medulla turn up the sympathetic nervous system in a way to make sure the body is being adequately perfused. This leads to also an increase in the systolic blood pressure and therefore an increase in pulse pressure. Another situation is aortic regurgitation. So the regurgitation of blood in diastole is going to lead to the increase in the end diastolic volume. So the left ventricle now has to pump even more blood in systole for the next cycle. This will increase the systolic pressure in the aorta and increase the pulse pressure in our equation again. So now we have one left to discuss that is much different than the rest. You will often be taught that as patients hit 55 years of age, the systolic pressure will continue to rise, while the diastolic pressure levels will actually kind of start to level off and maybe even decrease. Yeah, getting old is weird, but that just does not make any sense, does it? Well, it kind of does, if you consider that arterial compliance, which is the change in volume divided by the change in pressure, is directly proportional to the amount of elastin. So the amount of elastin in the aorta decreases as we age. This is because our fibroblasts burn out, just like probably you're doing for step 1. So this decrease in elastin leads to a decrease in the compliance. When you have a decrease in the compliance of a vessel, it cannot stretch and bounce back as well. Think about it like an old rubber band you found in a drawer that is hardened. Stiff arteries are not good at expanding to handle the incoming blood from ejection. So you get a huge spike in the initial systolic blood pressure reading after each systolic event. So this huge jump in systolic pressure will increase the pulse pressure. Now one more thing to cover. This is exercise. In exercise, we activate the sympathetic nervous system. We initially increase our cardiac output by increasing our heart rate and our stroke volume. But as we continue to exercise, the stroke volume will actually plateau, but we have to continue to increase our heart rate even more to compensate. Now why? Well, it's because we have a limited amount of blood volume in our circulation, and we can only venoconstrict to a certain level. We cannot continue to increase volume return to the heart anymore, but we can still control the heart rate, right? So that's why when you get a really good workout, your heart rate will be through the roof. All right, done with the equations. Now we have to talk about the principles behind these variables.